Thank you and welcome everyone. Good morning. We are going to go ahead and get started. We are at the top of the hour. So good morning and thank you for joining the Superior Health Quality Alliance Nursing Home webinar entitled Sharing Nursing Home Experiences with Telemedicine During Coronavirus Disease 2019. Superior Health is comprised of 8 member organizations across 6 states. Our goal is collaboratively to improve the quality of health and healthcare for consumers, patients, clinicians, organizations, and the communities we serve. Our role in the COVID-19 crisis is to connect organizations to communicate, clarify, and share resources. My name is Julie Bannister. I will be your moderator for today's call. I will be assisted by my colleagues, Tony Kettner and Candy Hansen. I'd like to take this opportunity to welcome nursing homes in Michigan, Minnesota, and Wisconsin to today's call. As a reminder, this session will be recorded and will be made available to you shortly on our YouTube channel. You may locate the video by searching Superior Health QIO. For your convenience, the YouTube link and the link for today's slide presentation will be located in the chat. There will be a short survey available at the end of the presentation portion of the call. Please note, all lines will be muted during the call. There will be an opportunity to ask questions during the Q&A segment after our speakers have presented. You may enter questions during the presentation in the chat box by activating the chat function, which is located at the bottom of the screen. For those joining by phone, to ask a question after our guests have finished presenting, simply unmute your phone by pressing *6 on the telephone keypad. Once you've asked your question, please mute yourself again by pressing *6. Our speakers today are Ms. Alison Romstad and Dr. Justin Di Rezze. Our first speaker, Ms. Alison Romstad, has served as a geriatric nurse practitioner and supervisor since 2004 for M Health Fairview, a collaboration among the University of Minnesota, University of Minnesota Physicians, and Fairview Health Services. Ms. Romstad is currently practicing as an advanced practice nurse. She is president-elect for the Minnesota Association of Geriatrics Inspired Clinicians, also known as MAGIC, where she also sits on the board of directors. Additionally, Ms. Romstad is on the board of directors for the Minnesota chapter of the Society for Post-Acute and Long-Term Care Medicine, as well as American Geriatric Society. She is past chair and an active participant for the on-site geriatric organization Collaborative. As an early adopter of video visits during the COVID-19 crisis, Ms. Romstad has successfully implemented telehealth practices into her long-term care, transitional care unit, and assisted living patient care environments. Our second speaker for today, Dr. Justin Di Rezze, is the CEO for Theoria Medical 5-Star Telemed, a comprehensive medical group that incorporates technology with superior patient care to provide the canvas for positive patient outcomes and re-landscape the way in which healthcare is delivered. A native of Michigan, Dr. Di Rezze attended Wayne State University School of Medicine, where he graduated with distinction. He completed his residency training in internal medicine at Ascension St. John Hospital and rose to the position of chief hospitalist at Ascension Genesis Hospital. Dr. Di Rezze's vision for improved management of patient transition from hospital to rehabilitation and skilled nursing facilities has been realized in Theoria Medical and 5-Star Telemed. Dr. Di Rezze states, if you combine evidence-based medicine, providers who have unwavering dedication, and cutting-edge technology, an environment is created for the best patient outcome. Just a reminder, please, you may enter questions during the presentation in the chat box by activating the chat function, which is located at the bottom of the screen. For those joining by phone, after our guests have finished presenting, you may also ask a question simply by unmuting your line, press *6 on the telephone keypad. Once you've asked the question, please mute yourself again by pressing *6. The questions presented to our speakers today include, during the COVID-19 crisis, how have you used telemedicine? Can you describe the telemedicine barriers you've experienced? And what pleasant surprises associated with telemedicine have you encountered? We will hear first from Ms. Romstad, And following Ms. Romstad, Dr. Di Rezze. So Ms. Alison Romstad, welcome. Please unmute your line. We invite you to respond to the questions.
Thank you for having me. I was joking at the beginning of this session when I logged on is we had technology problems at our house this morning. So our internet went out, so I had to drive into town. We do live rural and we just didn't have enough bandwidth on our LTE. So I'm sitting in town now in my car. So I apologize for the abnormal background in my video. But thank you for having me. I speak from a group of collaborative providers, physicians and nurse practitioners and PAs, which is CPAC and MAGIC. CPAC is a group of a collaborative practice alliance committee, and we're part of MAGIC, which is the Minnesota Professional Geriatric Group. And we have our websites attached, I believe. And we work together to do best practices and just help each other all out to elevate to the level where we all want to provide best care for our geriatric patients. We had a pre-planned meeting on March 16th to talk about lots of other things that we were working on, EKIT standardization. And of course, that all went out the window and we solely talked on COVID experience. And at that time, we as a collective group of providers all said, let's stop on-site visits as best we can and optimize the telehealth experience. And so from that day on, most provider groups within the metro and outside metro of Minnesota moved to telehealth. And at that time, we were just trying things. We were all doing different types of avenues. We were using Zoom and FaceTime. Duo were some of the front runners. Microsoft Teams we tried out. M Health Fairview has Amwell, which is their platform. And then we're starting to play around a little bit with Doximity as well. And what we found as far as barriers, we completely acknowledge that the burden of the work falls to the facility staff. We have to coordinate with the facility staff, and they're the ones walking around with the technology on their end. And it's an increased amount of time on their end where they didn't have to before. Historically, when we came into the buildings to see patients, we were pretty independent and didn't lean on our facility staff members to hold our hands or do things. We would always jump into their EHRs and glean the information that we needed ahead of time. And so it was very much a collaboration between facility staff and providers, but now it's the burden of the work is on them where they have to be with us at every visit. Facility staff have done some amazing things as far as how they can best optimize this. They do a great nursing assessment ahead of time on the patients that we plan to see. They, schedule the patients at a good time of the day that works for them. Some facilities are optimizing who runs the technology. So sometimes it's a chaplain. Sometimes it doesn't need to be a skilled nurse that I'm taking their time away to hold an iPad on that end. So definitely those are the barriers of time. And then also just bandwidth. We had to bandwidth on the facility side. Some still are in these beautiful old brick buildings and just really tough to get access into some of the patient rooms. When we were on site months ago, before we jumped to telehealth, we all had good technology in it, but it didn't always go into the patient room. Sometimes you had good bandwidth in the hallway, and as soon as I brought my laptop into a patient room, it would drop. And that's we're still experiencing and that. So I know some facilities have been getting boosters and kind of increasing the optimization of how their signal goes throughout the building. Some of I think the benefits or the surprises that we've seen is really nurses just rising to the level of meeting us where we need to be to perform great healthcare. So nursing assessment has improved, nursing skills. communication. I think some of the homes that we work with, we've been just pleasantly surprised with how nursing has really stepped in and elevated their skill set to meet this crisis.
Thank you very much. And I thank you for acknowledging our heroes in the healthcare crisis and providing insight into the use of telemedicine in your practice during COVID-19 crisis. Do you have any additional comments you'd like to make before we move into the next segment?
Yeah, so again, going back to MAGIC and CPAC, kind of the variants of it. So MAGIC is our geriatric professional organization, and you can MinnesotaGeriatrics.org. And then CPAC is one committee of that group, which is the clinical practice of it. And we've been working really well with all the different organizations that provide on-site geriatrics in Minnesota, and we have a lot of great resources and links. And so feel free to browse, glean, take it all. We're trying to just help out facilities as best we can. And as providers, I think we've really appreciated the telehealth. I think all of us are starting to acknowledge what now. You know, we've done it now for 6 weeks. What does the next 6 weeks look like? So that's kind of what we do. Certainly don't know what the future brings.
Thank you very much. Thank you for the insightful comments. Okay. And now, Dr. Justin Di Rezze, we invite you to also to respond to the questions. Welcome.
Hi, good morning, everyone. Thank you so much for having me today. It's a great pleasure to be here and to present to everyone on telemedicine. So I think our model is a little bit different from what Alison was speaking to, although it gives me great pleasure and happiness to hear the acceptance of telemedicine. But I think our company is slightly different. Our group is slightly different in the sense that telemedicine, we've been utilizing it for the past year and a half, almost 2 years. So everything that we had in place, I think, was already in preparation for a situation like this. And actually, I reviewed some of our statistics yesterday, and to show you the proof in telemedicine and the utilization of telemedicine, particularly in post-acute care. One of our facilities, actually multiple of our facilities, but one facility in particular, we only had one send out in the past 30 days. And this is a facility that has received 70 to 80 admits over the past 30 days. And another one of our facilities only had 3 send outs. And so we pride ourselves on low return to hospitalization. So I think if anywhere you can see the benefit and proof in telemedicine is in a situation where there's stress on the system and the system has not broken down. And I think that that's the situation that we're seeing here. We've been using telemedicine a great deal, and our group has not only utilized it for overnight care and weekend care, in addition to our weekend rounding, but we've also utilized it in specifically COVID designated buildings. So we are providing the medical management and medical directorship for a specific COVID designated building in Detroit, and then also several other buildings in the suburbs. And within these buildings, these patients are all have either COVID positive tests or have had COVID positive tests in the past, and either were transferred from a different facility or transferred directly from the hospital. So super high acuity, super sick patients. And with the utilization of telemedicine, we've been able to keep the return to hospital rate out of that building at less than 10% for all payer, all cause. So I think that that's the real proof in the use of telemedicine during this pandemic. And just to give you an idea of how much telemedicine has been utilized in that specific facility and in all of our COVID designated buildings, oftentimes if the patients are COVID positive and also elsewhere in buildings that have COVID positive patients, the provider that is physically there on site, if it's not an urgent or acute decompensation, they will actually round on that patient while they're in the building via telemedicine. This way they're not exposing themselves, and this way also they're not carrying it from that patient's room to perhaps a COVID negative patient in the buildings that do have a mix of patients. So with this, I think that we've really been able to protect our long-term care patients. We've also been able to alleviate the transfer of the virus from patient to patient in the skilled population when you have mixes of positive and negative patients. And we've really been able to utilize telemedicine to the full effect and really be able to deliver high quality care to these patient population within the post-acute care facilities. The other flip side of it, I think, is that the facilities that we aren't physically in and we're providing only telemedicine to, we've been able to provide a service to patient populations that would otherwise have seen a break in their care, particularly when it comes to rural areas. In Michigan, we have all of northern Michigan that is limited access to healthcare. And then once you get into the Upper Peninsula, you even have a more greater limitation on access to healthcare. So in those areas, we've seen particular utilization and great improvement in the delivery of care that we're able to provide because of telemedicine. Whereas if you would have backtracked 20 years ago before telemedicine really became strong, those patients would have seen a deficit in care, in my belief, just because of the limited resources that are available to them. Some barriers, I'm with Alison when she says that it is a stress on the staff in the buildings that aren't COVID designated, and perhaps the physical rounder has left for the day, or the physical rounder has completed their rounds and are no longer on site, and we need to utilize telemedicine for a quickly decompensated patient. Anyone that's clinical during this pandemic can tell you that these COVID positive patients decompensate rather quickly, particularly when they've come from an acute setting such as a hospital, or if they've been transferred from an LTC or to LTAC and have come over to a post-acute care facility. These patients are extremely high risk for decompensation. So there is a decently large or notable burden on the staff within the facility compared to the burden that they were under previously. Now, for us, again, the nursing staff, nurse managers, seen as our staff was always used to wheeling around our cart. So we actually have a telemedicine cart on all of our sites that includes a stethoscope, a 12-lead EKG, ultrasound. It has everything on it to allow for us to do a full assessment. So the staff in certain buildings have always been acquainted with the device and have always been used to delivering the device to the patient's room in some sense. I will say, though, that being said, even though that they're accustomed to that, they're still seeing an increased burden on them simply because of the volume needed in terms of patient care now and delivering the unit to patients' rooms. So we alleviated that some, as I said, that we have the provider on site and they're able to kind of help and assist with that and rolling the device around. And then we've also had to get creative and innovative in terms of who is able to do the assessment and who actually does it. And again, in alliance with what Alison said, utilizing other staff and saying, hey, we don't necessarily need a registered nurse to accomplish this task. It can be a CNA, it can be someone who is by the bedside because they're under the direction of the physician to complete the assessment. I think that some things that have really been pleasantly surprising throughout this entire pandemic are that the acceptance of telemedicine from our older patient population as well as family members has been increasingly abundant. I think that the acceptance, particularly on the family side, was surprising to me because I didn't think that there would be the willingness of assessment virtually from family members, particularly wives of elderly patients, people that are in their 70s, 80s. I didn't think that there would be that acceptance, but there has been. We've seen an overwhelming acceptance from our patient population. We've actually had families send us emails and call us and tell us that they're so happy that we're there to take care of their loved ones, and they feel relieved that the exposure to their loved one, if they are COVID negative, because we are also utilizing telemedicine for that. If we do have a building that only has a few cases, if that provider has rounded on that patient that week, we will try to limit actual physical contact and also round via telemedicine. There's actually buildings that we have been rounding in telemedicine to fulfill our physical rounding as well. So we've actually pulled the physical rounding provider and we have them rounding solely via telemedicine. And from that building in particular, we received multiple letters and emails from family members saying like how grateful they were that we weren't putting a provider in there to expose their loved ones to COVID, and we were preventing the spread of COVID throughout the building. And actually that building to date has remained COVID negative throughout the entire building. And so I think that just the acceptance of the new technology and the ability of our families and our patient population to adapt to the change has just been particularly surprising for me. And I'm actually impressed with the acceptance of it. And for us, it's motivating. It's motivating to take it to the next level and to really build out and figure out the next innovative step in terms of delivering fantastic and superior care to our patients.
Great. Thank you, Dr. Di Rezze, and thank you both for providing valuable information regarding the use of telemedicine and the benefits of telehealth in this changing environment. Please remember, audience, to complete the short survey available. We are going to open the lines now for questions. For those of you joining by phone to ask a question, simply unmute your line by pressing *6 on the telephone keypad. Once you've asked the question, please mute yourself again by pressing *6. Tony, do we have any questions for our guests in chat at this time?
Let me just take a quick peek here. Oh, yes, there is a question from someone asking, could you please repeat what items you have on your telemedicine cart?
Sure. So we have several different models. We have our Apollo model, which is our transportable model. That's the model that we've been using in the COVID units. And that model is able to be built out with everything from an Abbott iStat. So we are the only telemedicine solution that is integrated with Abbott's iStat for labs within the facility. In addition, it can have a Philips ultrasound, and we're also able to integrate that with any of our other models. And then we have a Littmann stethoscope. It's a Littmann 3200, and all these tools are all Bluetooth. Nothing is wired to the actual device. So the nurse is able to pull the device out, bring it to the patient's bedside with the screen that the patient is seeing. The doctor is also viewing the patient. And then also they have a 12-lead EKG on them that doesn't require any disposables. It's a wipe-down 12-lead EKG. It's from a company that's out of Europe. They bring unbelievable technology to the healthcare environment that allows for a 12-lead EKG to be completed via Bluetooth. And then in addition, we have the ability to add otoscope, 1080p camera. So most of the units have the basics, which is the 1080p camera, the 12-lead EKG, the Littmann stethoscope, the 1080p hand cam that allows for like wound assessment, because we also do wound rounds via telemedicine. And then we also build them out with, like I said, the Abbott iStat and the Philips ultrasound.
Thank you. Do we have any calls on the line? Any questions? Again, if you press *6 on your telephone keypad to unmute yourself.
We do have another question in chat for Dr. Di Rezze.
Sure.
Can you talk a little bit about the logistics of providing services such as scheduling and sharing of records and electronic health record integration?
Of course. So we're fully integrated with point-click care. Again, we're one of the only telemedicine solutions that we're also integrated with their secure messaging system. So we have a great build out with both PCC and Tiger Text or Tiger Connect, who provides the secure messaging service for any of the buildings that are using the secure messaging. That's the messaging box that's at the top of point-click care and integrated. So we have full integration with that. And then also as far as scheduling, it depends on the building. Some buildings use our app. So we actually have an iPhone and Android app, an iPad app, and also a cloud app that could be accessed via Chrome or whatever you're using in terms of your internet provider. And then we also have buildings that use the dashboard within point-click care. So it just depends on the building. It varies depending on who's doing the actual encounter, who is rolling the cart around, and so once we figure out all that logistically, I mean, our whole goal as a group when we go into a building, whether it be with medical providing or telemedicine, is that we provide the least ripple effect throughout the building. So we really are agile in terms of integration and execution. And so whatever the building really wants, we try to integrate and maneuver around that so that we provide the least transition steps and barriers as possible.
Thank you. And Tony, any questions on the phone line at this time?
None that have come in, and I see no additional questions in chat.
No additional questions.
Right. This is Candy. I have a couple of questions, if I could ask.
Thank you.
Sure. Two questions. Number one, when you talk about the acceptance of the telemedicine or the telehealth to the patients and families, was there anything in particular that the homes have done in order to provide that education? That's my first question.
Yeah, so I'll break that into two segments. So I think there's two types of integration and acceptance we're talking about with telemedicine. So with us, there's the buildings that we've been in even before this whole pandemic. So those buildings have always been very accepting of telemedicine overall. I think the buildings that I was more referring to are the buildings that we've recently launched telemedicine in. And so as far as support from the building, at the time of admission, if it's a short-term skilled patient, at the time of admission, the admission process includes a detailed explanation of what telemedicine is and what it includes, and also obviously the consent. So they incorporate all of that at the beginning of time of admission. For the long-term patients that are within the facility, there's also education that involves our providers on staff, and then also the building. So I think for when we launch telemedicine into a building, it happens in two segments. So the first segment is obviously addressing everything with the long-term care patients that are in the facility because they live there. That's their home. We're bringing in this new technology to their home. So there is that acceptance that we want them to have of technology because we respect the fact that this is their home. So we do ask them, is this something that you guys are okay with? And I will tell you that in our experience, we run a 98.6% acceptance within long-term care patients. And if you project out 3 months, we have a 99.8% acceptance of long-term care patients when it comes to signing up for telemedicine and giving the consent. So that shows you, getting over that consent and getting over the barrier of allowing them to have telemedicine within the facilities there's a very low threshold. They are extremely accepting of it. And I think it's because of the way that the building presents it and also we present it. We present it in the fashion of truth. The truth of it is that by having telemedicine and allowing telemedicine in this building, we're now able to provide every patient within this facility 24/7 care. And I think that if I may just go into a little more detail, the reason that we express it that way is because our telemedicine solution is not just a fire extinguisher. So other competitors that we have within our region of telemedicine and post-acute, they provide a solution that is a fire extinguisher, meaning that you contact them for a problem. We are always there via secure messaging. So for example, last month, our highest building volume that we had is a 140-bed building. They get about 80 to 90 admits, and we had 33,000 text messages from that building in a 30-day period. And that's not including telemedicine calls. So to give you an idea of the volume, and that building had 165 telemed calls. So that's the level of involvement that our providers have. So when you show a long-term care patient that or family and you give them those details, the first question that we always get, well, who would take care of these issues if you guys weren't on? And that's our point, is that you need this. We need this in order to support you and to take care of you overnight and to make sure that things are going well. And I think that if anything, it gives them a great sense of relief, knowing that there's always someone there. There's always a provider there to take care of them. There's always someone there to answer questions. And we show that to families when we're making either like an end of life call at 2 a.m. because a patient's decompensating, or we're calling family to let them know what's going on. So once you get a couple of those cases within a building, that news spreads like wildfire through the building. And then all of a sudden you have all these families that are like, okay, well, hang on, why don't all buildings have telemedicine, when they hear of the acceptance amongst patients and families?
Thank you. Ms. Romstad, are you also seeing that immediacy of availability as an encouragement to the residents in your care?
Yeah, so speaking solely for my clinical practice, we're available, our primary care providers are available 7 a.m. to 8 p.m., and we can do video visits at any point in time. Again, kind of having the onus on the nursing staff of seeing when they're available first. And then after hours, we don't have video visits yet set up. So I think that that's beautiful to do it in the middle of the night, because absolutely what Dr. Di Rezze said, that's when the fires happen. So true. Beautiful.
Thank you. Thank you. Okay, it looks like we are nearing the end of the call here. I want to thank both of you so much for joining us and providing us some insight into how telemedicine is really burgeoning in this unfortunate environment. On behalf of Superior Health, we would like to thank our special guests and thank you for attending. I would like to announce, please join us on April 28th for an additional telehealth webinar entitled Nursing Home Telehealth Policy, the Basics of COVID-19 Implications. Our guest speaker for the event will be Dr. Meg Kwong, Executive Director for the Center for Connected Health Policy, the federally designated National Telehealth Policy Resource Center. So that will be on April 28th, and invitations will be forthcoming. Again, I'd like to thank our guests. We really appreciate your input and taking time out of your very busy schedules. Thank you for keeping our residents safe. And without further ado, we thank you for your time.
Thank you, everyone. Thank you for having me.
Take care.
Thank you.